Good evening to you all and welcome to the annual general meeting of the Aneurin Bevan University Health Board, which covers the financial year 23-24. Nos diwetha, a croeso i gyfarfod cyffredinol blynyddol Bwrdd Iechyd Prifysgol Aneurin Bevan ar gyfer blwyddyn araniol 23-24. Today's meeting is being held in public, which means that we are joined by our staff, our stakeholders and members of our communities. Thank you very much indeed for coming today. We're really pleased that you've been able to join us. A recording of the meeting will also be available on YouTube for anybody wishing to view it at a later time. The organisation over the last 12 months and still to the present has been under exceptional pressure. We've had a huge increase in demand from our population, and this has not just affected us, but it's affected our partners in social care. Despite this, there have been many achievements and improvements, and we have to pay tribute to our staff for the way which they have retained their professional approach to good quality patient care, and we are very pleased with the reports that we have back on the outcomes for people within our services within the Gwent area. Some of our improvements you will hear about this evening, and of course many additional ones are included in our annual report, which I would urge you to read. However, we cannot get away from the fact that we appreciate the concerns and frustrations of people who are waiting. It is extremely frustrating for you all, and we are striving on a day-by-day basis to improve your access to care. We have made improvements this year and going into the current financial year, but we are well aware of the difficulties this causes to you all, for which we are very sorry, but we are all really racing to try and keep up with the demand and to serve you as you deserve. Shortly, we will welcome questions from you, those of you who have joined us, and thank you very much to those of you who've sent in questions in advance. You can continue to ask questions in the question and answer facility on Teams. We will attempt to answer as many as we possibly can, but if we can't deal with them all, then you will receive a written response within the next week. I should like to hand over to Nicola Prigodic, our Chief Executive, who will start by presenting the highlights of our performance during 23-24. Thank you, Nicola.
Diolch, Chair, and noswaith dda. It's a real pleasure to kind of share with you an overview of our achievements throughout 23-24, and I just want to echo the comments of the Chair about the huge amount of work that is going on across the Health Board, and the exceptional hard work of our staff who go above and beyond to continue to deal with what continues to be a very challenging environment. As the Chair mentioned, there is a detailed performance report, but I've tried to pull out some of the key headlines from the report in a presentation that we've got. Dan, we're going to just share, if we go straight to the key achievements slide. Again, this is just a flavour of some of the main achievements during 23-24. We continue to review our services to make sure we are providing the best evidence-based care that gives the best outcomes for patients. And during this year, just to name a few, we reconfigured our stroke rehabilitation services to make sure we could enhance the service for patients and the therapy support. We reviewed our minor injury unit provision, and we also reviewed our maternity services, again responding to patient choice and preference of patients, particularly around maternity services. We opened a new endoscopy and a breast unit, two fantastic facilities that we're already seeing the benefits of through better and improved diagnostic and cancer rates. and already getting some really good feedback from patients around their experience of those 2 new units. Cancer is a key priority for us as a health board, and we are trying to be as innovative as possible, and we have a number of artificial intelligence pilots which are showing how quickly we can improve cancer diagnosis times, and we continue to learn from these and roll out as much as possible. The 6 Goals programme for urgent and emergency care is a very comprehensive programme that we've got to improve the work on the patients who need urgent and emergency care, right from presenting in an ambulance or a minor injury unit, right the way through to needing discharge back home. And the programme of work reviews all of the opportunities to improve across that system. And we have seen improvements in the length of delays of patients waiting for discharge, working with our social care partners, albeit there's still a number of challenges across the system. And we are seeing improvements in our ambulance handovers and waits in the emergency department. But as I'll come on to later, we've still got a lot more work to do in this area. As we mentioned, we know there are huge waiting lists for patients, particularly waiting for outpatients and treatments. And we've particularly been focusing on those that were waiting more than 3 years. We had over 500 patients waiting at the end of March 23, and we reduced that to just 31 patients. And we are on track to reduce that to 0 in the coming months. We've got 30 of 36 specialties that are now delivering treatments within 104 weeks, 2 years, and many of those are delivering their treatment within 52 weeks. So we're making some really good progress, albeit we do still have a number of specialties, particularly in orthopaedics, ENT and ophthalmology, where the demand is continuously stripping the capacity we've got, and we are working hard to look at ways in which we can address those particular areas. We opened the Bevan and Health and Wellbeing Centre up in Tredegar, which is a fantastic facility where we've centralised some of the GP practices into there with our community services to have a central hub for that population. And this is a model we are rolling out in other areas of the health board. We had 5 practices that we were having to manage ourselves as a health board. We were struggling to recruit and maintain services in these areas, and we successfully managed to secure independent contractors to take over these practices, which are already showing signs of improved sustainability, which is excellent. We put a huge focus on our workforce, and we're really keen to make sure we reduce the reliance on agency staffing, trying to build sustainable teams. And we've reduced our spend on agency staffing from £60 million a year down to £42 million a year, a reduction by £18 million, which is a huge effort by staff through improving recruitment and retention, which I mentioned a bit later down, where we've increased our substantive workforce by over 500 full-time equivalents during 23-24, which is a great opportunity for our population as well, and it demonstrates the efforts and the success we've had around building our local teams and reducing the reliance on agency staff. We've had a huge focus on finance and efficiency. We all know that there's a significant financial challenge in the NHS in Wales, and we have delivered a record savings delivery last year of £43 million to try and improve the financial position of the health board and put us in a more sustainable position for the future. We've got a real refresh focus on prevention. We all know that we need to try to avoid people becoming ill where we can and helping the population stay healthy and well. So we've refreshed our focus, and we did a huge amount of work with our partners around understanding the needs of the population. We've had a relentless focus on quality and safety. We make sure all of our services are improving, and we're also conscious of people's experience and their outcomes, including a real focus on mortality and making sure that we are improving across all elements of the service. And what is quite an important point is, since we've opened the Grange in our new system, we have seen improvements in hospital mortality rates, which is showing the benefits of the centralised model of care that the Grange Hospital offers. In terms of the patient experience, we have had a focus on complaints and our ability to respond to issues when families and patients are in our services, and we've introduced a new patient advice and liaison service. at some of our hospital sites and primarily at the Grange to make sure people can get support if they need to around dealing with any concerns they have. And we've also working on our bereavement offer to make sure we can support families and members of the communities around our bereavement offer when they lose their loved ones. We've also focused quite a lot internally in the organisation around our communication and engagement with staff, because looking out for staff and making sure we understand their concerns and issues is a key priority for us. So there's just a flavour of some of the achievements. There's many more in the detailed document. I'll pick up a few more in a second, but that is a very high level overview for the year. If you go to the next slide, Dan, I wanted to just pick up, whilst we've delivered all those achievements, as the Chair mentioned, we continue to face a number of key challenges, many of which are not unique to this health board. They are symptomatic of the challenges the NHS is facing nationally. One of the first one is the growth in demand and increasing acuity of patients, and particularly since the pandemic, we have seen huge increases in demand. We have seen over 30% increase in cancer referrals coming into the health board, over 20% increase in our outpatient referrals. We are seeing increases in our emergency demand at the emergency departments, and the acuity of patients as they come in. And we know our population is also getting older, and we need to make sure we can respond to those changes. Financial recovery, I mentioned the financial context. The pandemic, we know that we went through a significant period of increased costs, and we are now trying to get our costs back under control and to live within the resources that we've been allocated. So we've been spending a lot of time to make sure our services are efficient and we are providing good value for money across our services. We have a number of estate challenges. Many of you will have visited some of our sites, some of which have got excellent facilities and some of which we know we need to make decisions. And St Willows Hospital is one area we're looking at, particularly the older part of the estate. And also we know that we've had challenges around Neville Hall with the rack, the concrete issues, and therefore we have got a redevelopment plan developing around that estate. We continue to look after the workforce and make sure we keep morale. Our work around recruitment and retention, reducing agency is just one element of that, but also investing in training, wellbeing support are some key priorities. But we know the pressures that the increase in demands of the NHS are putting on staff. And then finally, I mentioned urgent emergency care improvements, but we are showing really positive signs, but our ability to sustain that continues to be a challenge, because the peaks and troughs we see in demand does sometimes challenge us and our ability to maintain those reduced waiting times that we are seeing on many occasions. And these are the key areas that we will be focusing on as we're into this year and beyond. If you move along, Dan, thank you. So I'm not going to take you through all of these, there's lots of detail in the report, but I'm just going to pull out a few of these under these key headings. So under the prevention agenda, I just want to draw your attention to the work we've been doing around vaccines. Making sure children receive their vaccines by the age of 1 is crucial in terms of making sure we protect children as much as possible. And we've got a lot of focus on children and the first 1,000 days of making sure we give children the best start in life. And as a result of the work we've done with partners around understanding the needs of our population, there's a lot of work going on around women's health, particularly when you look at the mortality rates for women and the inequalities, particularly around women across our health board area. And we've also refreshed our focus on diabetes and cardiovascular disease, where they are key prevention programmes to address some of the challenges that those diseases present. Primary care GPs are a huge priority, and we are continuing to look at how we can increase accessibility and the quality of services in primary care. And we've increased the number of GP appointments that were delivered last year, and constantly looking at how we can improve the access and the communication with GPs as well. Community pharmacies are continuing to provide a crucial role, and we've seen a huge increase in the common ailment scheme. These are where you can go to your pharmacy for particular ailments without needing to go to the GP. And similarly, dental services, again, we know there's challenges for dental services, but we have increased the availability of dental care with 24,000 new patients accessing services last year. If you move on to the next slide, Dan. Thank you. In terms of mental health and children's mental health, again, a key priority area for us, particularly trying to make sure people are assessed within 28 days and then they receive interventions within 28 days. Again, another area of significant increased demand. And we have been doing a huge amount of work to increase our capacity to meet this 28 days. We have been struggling. It's a particular challenge, but we've got a very clear programme of work which is ensuring we can hit this 28-day target in this financial year, with very positive signs recently of where we're delivering against that. And likewise, our under 18 access to mental health services is better this year compared to last year. And again, more work to do, but we're going in the right direction. And CAMS is a key priority for us as a board to make sure we support children with their mental health issues. Urgent and emergency care, I've mentioned a few areas. There's a huge number of schemes we're putting in place to try to make sure we can avoid people coming into hospital when they don't need to, and make sure that we can get the handover those ambulances as quickly as possible at the Grange Hospital, and reduce the amount of time people are spending in the emergency department. All of that is inextricably linked to our discharge position and making sure we can get people home from hospital as quickly as possible. And the other element is our minor injury unit is a really good model. We have hugely positive feedback from our minor injuries, and they ensure only those who need to be at the Grange Hospitals or acute emergency department need to be there. And our 4-hour target is one of the best in Wales across the system. Okay, and the last 2 areas, in terms of planned care, I mentioned the improvement we've made around the 2- and 3-year waits. In terms of outpatients, we continue to try to, instead of keeping people on a follow-up waiting list for many years, we introduced patient-initiated follow-ups and see on symptoms, so patients can come back to us with easy access if their symptoms return. And we've also made improvements in terms of people waiting more than 8 weeks for a radiology test. That's another area of pressure, hugely increased demand for radiology tests across the system, but good improvements in terms of halving the number of people waiting more than 8 weeks from November to March. I mentioned cancer earlier. Our endoscopy suite and breast are making significant differences, and we are treating more people than we've ever treated before for cancer, despite the increase in demand. And we are hoping to improve the 62-day target for definitive cancer treatment even further in this financial year, but we did make improvements throughout 23-24. So the next slide, if you look at the report, we also try to look at our performance through the lens of the life course, looking at our services right from when a baby is born and just before they're born, right the way through to people who are at the end of their life, and making sure that we give people a good positive experience, and families at the end of people's life as well. And you can go through the report and see how we look at it through this lens, but pretty much I don't want to repeat some of what I've already covered. So I leave it there, Chair, if that's okay, in terms of a high level overview of some of our achievements. Thank you. I think you're still on
unmute yourself.
Thank you very much, Nicola, and thank you for drawing out those really important improvements and aspirations to improve that we are pursuing as a health board. I'd like to ask Rob Holcombe if he could present the financial accounts, please.
Thanks, Chair. So if I go to the next slide, please, I'll give an overview of the accounts. So our accounts are audited by Audit Wales, and they perform that audit to allow the Auditor General for Wales to provide an opinion. Another positive year for 23-24 accounts with very minimal amendments following the audit review. So 2 forms of opinion are given. Firstly, in terms of a true and fair view of the way the accounts have been prepared and reflective of giving a properly prepared presentation of the finances of the organisation, and that was approved by and signed by the Auditor General of Wales on the 12th of July. So our funds have been applied appropriately. There's a second opinion on the regularity of our accounts, and we have been qualified on that basis because of the deficit that we've reported. As an organisation in Wales, we have a spend approved, which is our resource limit. And unfortunately, due to some of the service pressures and demand pressures and the requirement to provide safe healthcare to our patients, unfortunately, we had to overspend against that limit. As a result, that is deemed irregular expenditure because it wasn't approved by Welsh Government, and as such, we have a qualified opinion on our regulatory position. So I can next slide, please. So in terms of our performance from a financial perspective, we have two resource limits, which are in effect approved spending limits from Welsh Government. One is revenue, which is our general operating costs, and reflective of the opinion just given, we in 23-24 incurred a deficit of just over £49 million. Our target is based on a rolling 3-year period, and our cumulative deficit over that period is £86 million, hence the qualification. Our capital resource limit, which again is a spending limit, related to things like infrastructure and buildings, etc., at a higher value. And we've achieved our resource limit for capital, both in 23-24 and on a rolling 3-year basis, as can be demonstrated there. So that's a positive for us. Next slide, please. The two further targets as a health board we have from a financial regime perspective. So we have a public sector payment policy which requires us to pay 95% of our suppliers within 30 days, and we've achieved that. And in terms of cash funding that we get from Welsh Government, every month on average we're expected to hold less than £6 million, and we achieved that throughout the year as well. So again, positive there in terms of our financial performance. Next slide, please. So where did we spend our money? So we had a revenue source from allocations, which is Welsh Government funding, and we had income generation of £122 million that supports that. That gave us broadly a £1.9 billion spend envelope or resources available to deploy and apply to our services. So that was spent on 3 headed areas, and the graphs break that down a bit further. Primary care services, hospitals and community services, and other providers where we commission services outside of our organisation, particularly specialised services that are purchased on an all Wales basis. And you'll see notably increases in our expenditure during the year on staffing, on GP services or GMS, General Medical Services, that's GPs in the community, and specialised services, as I mentioned earlier, which is a very specialised end of service provision, patients that wouldn't normally be provided within our types of services. Next slide, please. So looking at that further in terms of pay, we spent just over £800 million on pay and our staff in the year. And there was an increase, if you exclude pay awards, of £7 million, but quite a positive position reflected in Nicola's earlier slides around a reduction in agency costs. And agency costs cost us more per staff member than employing a staff member. So there's a premium to that due to the variable nature of that engagement. It's been a positive strategy by the Health Board to support further recruitment and employment of staff. It supports foundation economy. It improves the quality offering of staff and the overall economy of the area. Most of our staff live within the area, so that's a positive, as well as then where we're deploying staff to services and deliver services to patients, that premium rate is avoided. Next slide, please. In terms of some of the other spend analysis, so our hospital and community services, when we look at some of the non-pay costs around there, small decrease in some of our depreciation elements, which is a cost for maintaining our estate. Some key areas of cost increases around clinical supplies and services, so that would be things like joint replacements, consumables in clinics and in theatres and things like that. Decrease in premises costs largely due to the reduction in our utility costs this year, which is I'm sure being experienced by the general public as well in terms of energy cost reductions following the spike a year or so ago. We've spent more on primary health services, so this is GPs, dentists, pharmacies, etc. Particularly notable in GMS services, general medical visits to GP, 6.5 million, and an increase in prescribed drug spending, which is the scripts that are provided through GPs to patients. That's the vast majority of those, over 7 million increase there. In terms of healthcare provided from other providers, I've mentioned previously specialised services, which is commissioned nationally through the Wisconsin arrangements, 10 million increase there. A notable increase in our continuing healthcare spend of £30 million, and they are patient placements for patients that need ongoing healthcare. Most of those are in nursing homes. Next slide, please. So in terms of our capital spend, overall capital investment during the year is £58 million. The table there identifies our major bigger value projects. So I won't go through that list, it's there for reference. Some have been completed in year, notably the endoscopy service and the breast unit in YWF. And many of those other services then projects are ongoing as part of our development programme for capital and estate across the organisation going forward. Next slide, please. So moving on now to our charitable funds, and these are subject to audit, and that audit will be undertaken shortly before submission of the charitable funds accounts to the Charities Commission at the end of January 25. Key points to note that the charitable fund operates from donations from the public and wider community. The objective is for benefit of the NHS, public benefit, and focuses largely on staff and patient improvements and amenities and general well-being. As an organisation, the corporate trustees of the charity are board members, and a lot of the work is then delegated to the Charitable Funds Committee, who operate on behalf of the board, with a keen eye on making sure that the rules of the charity are followed in terms of making sure it's a public benefit for staff and patients in terms of expenditure approvals and the use of the funding. Next slide, please. So for 23-24, we received £0.8 million funding or income during the year, and we spent just over 1.2 million, and the differential would be covered from balance sheet and the resources held in charitable funds from previous years. Slide, please. And some examples of how we've utilised that funding for the benefit of staff and patients in year are identified in this page. So we've purchased equipment, notably defibrillators in the community through Jack's Appeal, building and refurbishment work for either charity assets or to improve well-being of certain areas for staff, things like staff rooms, patient education and welfare, and staff education and welfare areas, as you can see, that have quite a significant investment spent on them, as we normally do each year, and then support costs to run the charity are noted there as well. So I'll hand back to the chair, please, for the overview.
Thank you very much, Rob. I'd like to move on now to invite Hannah Evans, who's the Director of Strategy, Planning and Partnerships, to present an overview of what we're doing in terms of delivery of care for 24-25. Hannah? Thank you, Chair. So just want to spend a few minutes just outlining some of the key components of our plan for this year, for 24-25. We're now 5 months into delivery of this plan, which was approved by the board in March 24. So just briefly then, underpinning our plan, obviously building on the work that's already been outlined by Nicola and Rob there. Really important that whilst we're at this stage unable to deliver a plan that financially balances, we have committed to giving that 3-year outlook. So our annual plan has been developed and articulated with detailed for year 1, but with a 3-year outlook, and we continue to build on that approach for next year as well. We've got our quality strategy and the prioritisation of patient safety as the golden thread, as you would expect. And our focus on how we, in the context within which it's been outlined already, how we are deploying and using our resources to deliver us on our journey to sustainability and to drive most value is a real important foundation for our plan for this year, alongside our staff, and making sure we focus on both the wellbeing experience and the sustainability of our staffing model. So there's some of the principles that have helped shape the plan. So just the next slide then, if that's okay, just gives a bit of an overview of the framework we use to define our plan. And if you're familiar with the document, how it's described and set out. So what we've tried to do is be very clear on our service priority areas, so those system change priorities down the left-hand side, and I'll come on to those in a bit more detail in a moment. And whilst not losing focus through our value and sustainability, our financial and our resource imperatives, our thematic programmes, so really important, they're a key feature of our commitments and our delivery focus within the plan. But our plan also recognises that we don't work in isolation. As a health board, we work within a number of systems, so reflects our commitments with our 5 local authority partners through our RP, our regional partnership board arrangements, as well as through our broader partners and stakeholders in the Gwent region through our public service board commitments, and also how we interact and plan and deliver with health boards in the South East Wales region. So the plan is triangulating all of this information and commitments. And of course, Nicola's touched on already our life course lens, how we consider and challenge ourselves and deliver improvements through thinking of our improvements to the population health through the life course. So that sets out the framework for the plan, which is all underpinned by sort of the enablers, the things that need to be in place to enable those changes and improvements to happen. So just moving on then, in terms of just some of the specifics against those service priority areas, and they do build on some of the areas that Nicola's outlined in the successes from last year. So just briefly really then, under that one about prevention and population health, Nicola's mentioned the diabetes and cardiovascular work, and there's also under Tracy, our Director for Population Public Health, our focus on preventable premature mortality, so the specific interactions and interventions that we can take as a health board and as a system to reduce those number of avoidable premature deaths. So an important programme of work for us there, alongside the diabetes and cardiovascular work touched on. And also, and you'll have seen it in the Tracy's recent Director of Public Health report, our focus on the best start in life and in children, and this comes through our priorities and commitments around improving vaccination uptake, both in for babies, but also for children starting school age. A really important commitment for us this year. In terms of primary and community, some of the specifics is continuing the work on improving access. We touched on some of it earlier, but also embedding the new contract for optometry is really important. And also that next level then of facilities and development in our community. So it's the final stages of the new Bevan Health and Wellbeing Centre in Tredegar and completing the Newport 19 Hills Health and Wellbeing Centre. So really important, not just physical assets, but opportunities that bring services from health services, third sector and local authority services together to support communities in communities. We've talked about urgent and emergency care already through this update, and using the 6 goals to drive. So some specifics for this year.
is to try and recognise some of the challenges of the environment in the emergency department in the Grange, and so doing an expansion to the waiting area there to address some concerns, and continuing the already referred to sort of reduction and focus on delays for patients who are being handed over from ambulances into the hospital, a huge area of work in our commitments and our plan for this year. And also we're doing some service and have introduced already in the first half of the year some new services to support some of the improvements in flow, including an acute frailty service at the front door, linking community services and hospital services around the needs of frail patients who present. For cancer and planned care, we do and we are continuing to recognise the clinical primacy of cancer services and really driving the benefits of some of the developments already touched on, with a real focus as well on how we can improve the time to a diagnosis, recognising the experiences of patients in that wait whilst you are going through the pathway of scans or other diagnostic tests. We'll continue, and we are continuing to focus on long waiting patients, targeting action at some specialties that are particularly challenged in terms of the demand and capacity, and also focusing on how we use some of our very important resources with a focus on theatres and how we can get maximum efficiency through our theatres. So very detailed plans and commitments for this year. And finally, mental health. We've talked already about our early signs of improvement around our access to assessment and intervention services, a focus for us across children, young people and adults, and that continues into this year with some good progress as has been touched on being made. And also we recognise we've started work, but we've got more to do in terms of our improvements to our neurodevelopmental services, both for children and adults, and the improving access to those services. So just a few of the headlines in terms of the specifics under our change priorities. In terms of some of the enablers and the building blocks that need to be put in place across the bottom there, just drawing out a few. So our people are really important for the delivery of all of our services. It's really important that we look after their well-being. We work with our communities and partners around attracting people from them. So we've got a lot of work in terms of the pathways into careers and roles within the NHS. And estates, we have some big commitments this year in our plan around responding to some of our estate challenges. We've touched on RAC in Neville Hall, so our service and estate response, and our ambition to get out and relocate our services and our staff from unsuitable estates such as St Willis. Digital and technology is a huge opportunity for our system, for our staff, but also for our patients and public in how we access and how we provide services. So lots of work in train led by our digital director to take those improvements forward. So in terms of the challenges, these really, I think these have been covered already in terms of the challenges that this year we will be navigating as we try and deliver some of the examples I've just highlighted. I won't go through these in detail, Chair, because I think we've covered most of them. But there, in terms of just the final slide there, Dan, I think would just invite those on the call just to draw attention to the work we're doing about developing our new organisational strategy. So we are doing lots of work on looking at evidence, best practice and horizon scanning, and looking at the needs of our population through the various assessments and tools we have. Another component of that work is to listen and engage with our public and our communities. So we've done a lot of work already, but just wanted to use this opportunity to highlight it again and invite colleagues on the call and staff and members of the public to have a look at the website to see how we can have a look at the questionnaire or events that are coming up in your area, because we are still really keen to hear and listen to your views and experiences. Thank you.
Thank you, Hannah. That was a really good overview of what has been achieved. Now it's your turn for public answers and public questions and answers. Dan Davis, the Chief Business Officer, will manage this part of the meeting for us and for you. We will start with the already submitted questions, but we would like to invite you to actually tell us what your question is. Again, you can put your question in the Teams column, and we will endeavour to answer as many as we possibly can. So over to you then, Dan. Thank you.
Thank you, Chair. So, as the Chair said, this item invites questions for our board members, from members of the public. And in terms of technicalities, guests can now turn on their camera if they wish, using the guidance that we've sent out in advance of the meeting. If you are asking a question this evening, you have to just remember to unmute your microphone so that you can do so. That should work for you technically now. So as the Chair has said, we've already received a number of questions in advance of the meeting, but those who are joining us today can still submit a question by using the tab labelled Q&A, which tends to be at the top of your screen. If you click on that tab, you can ask a question that we will get to in a short while. If you do have any issues with any of that, just raise your hand using the raise hand function on Teams, and we'll be able to help. So we'll now invite each person who has already submitted their question in advance to ask their question to the board members, and then we'll come on to any questions that have been submitted during that time. If anyone's not with us tonight, we will still read their question and gain the response, and that is going to be the case for the first question, I believe, because we do not have Lorraine Morgan, unless Lorraine tells us differently. No. So Lorraine's question will be answered by Leanne Watkins, who is the Chief Operating Officer for the Health Board. And Lorraine's question is, why is there such a huge difference between the quality and services offered by GPs, and how are these monitored and evaluated and then addressed?
Thanks very much, Dan. Thanks very much, Dan, and thank you, Lorraine, for such a great question. So some of the difference can be explained by the fact that we have 68 general practices that provide care between the hours of 8 and 6:30 during weekdays. And these are managed through independent contractor models, as is the norm for primary care. As you'll also be aware, the population needs vary significantly across our health board boundaries, which contributes to some of the differences in the delivery of primary care that will be based on patient and population need. There is very detailed regulation and statute that support us in the management of these contracts. So the NHS General Medical Services Contracts Wales regulations from 2023 supports the implementation of a unified contract, which really simplified GP service deliveries across the system. This includes unified services, quality improvement, and also the provision of supplementary services, which means GPs can opt in to deliver additional services as they see fit based on their population needs. There is a very detailed contract assurance framework that ensures that general medical contractors adhere to quality, safety, governance and contract management standards. And we have a very robust primary care contracting team that monitors performance against these indicators, against a very detailed contract assurance framework. This is also triangulated with local intelligence and feedback from our population. In addition to this, I think the final thing I would just want to draw attention to is I chair a primary care sustainability board, and very importantly we have Llais, our patient representative, on the board so that the patient voice is strong and that the work that we're doing is very transparent and can provide direct feedback if they feel that there are any issues or concerns with primary care provision, service provision. So I think that explains it, but I'm sure that we will provide a more detailed answer to Lorraine via written feedback. Thank you.
Yeah, and that's right. We'll provide a written follow-up response to every question that's been asked today. That'll happen within 14 days of today's meeting. The next question is asked by Councillor Desmond Hillman. The question will be answered by Jennifer Winslade, who is the Health Board's Director of Nursing. Councillor Hillman can't be with us either. However, his question is, When are you going to address the problem with ambulances not making their attendance figures on time? Why haven't you got together with the local authorities to thrash out this care package plan issue that is causing the bed blocking in hospitals? Thank you.
Thank you, Dan, and thank you, Councillor Hillman. It's a really good question, and we work very much in partnership with our local authorities around, in particular, our patients who are delayed in the system. But if I return to the first part of the question around, ambulances not making their attendance figures on time, we have a very detailed programme of work within the Health Board through our enhanced monitoring improvement programme, and we've made really good progress on improving ambulance handover delays. We take very seriously our duty to our citizens to ensure that there are ambulances available in the community to respond to those most in need. So we do work very closely with our ambulance service colleagues. We work very closely on making sure we've got the right alternatives and pathways in place across our urgent and emergency care system. We have a flow centre that enables a conversation between the ambulance crew and our team within the flow centre to ensure that the right patient goes to the right hospital to meet their needs. And this ensures that patients get the right treatment as quickly as possible. In terms of how we work with local authorities, we do have a number of initiatives in place already to support the transition of patients who are medically fit, to make sure they either have a transition to their own home or to a care home facility, depending on which is most appropriate to meet their needs. We have a number of schemes in place where we work with the local authorities around trying to bridge that gap for people who are medically fit. And we have a number of initiatives. We have one called Hospital to Home, where we take patients home earlier in their care pathway when they're medically fit, and we provide that integrated response to them with our local authority colleagues. We have a integrated discharge improvement board. I chair that, and that sits within our urgent and emergency care framework, but we work very closely with our local authority colleagues to make sure that we jointly understand what is causing the delays in our system, but also to ensure those improvements are in place to make sure that we care for people as close to home as possible, which in most circumstances is actually far better in terms of the quality safety outcomes for their care. Thank you, Dan.
Thank you very much, Jennifer. The next question that we'll come to has been submitted by Councillor Marina Chacken-Dawson. Councillor is on the call with us. Would you like to ask your question live, Councillor? No. We'll ask it on your behalf then. This question will be answered by Hannah Evans, who's the Director of Planning and Partnerships. The question is, what are the priorities going forward? For example, are you reducing the waiting list, focus on care homes and or prevention of illness, etc.?
Thank you, Dan, and thank you for the question, Councillor. I'm hoping that in the update and the overview of our plan for this year, I was able to answer most of that question, Councillor, but keen to follow up if not. And I think the challenges, so the examples that were given in the question, is we have a number of priorities in a number of those, in all of those domains. We are a large organisation with a breadth of responsibilities from population health through to the delivery of specialist care. So we don't have a single priority. As I set out, we have some specific deliverables and commitments for this year in a number of areas. So the agenda, for example, around prevention and keeping people well is vast, but through using our the expertise of our colleagues and the data shows where the most benefit, we can get the most benefit from a patient outcome as well as resource perspective is, hence our priority in that space under being diabetes and cardiovascular, and recognising that the impact that a proper focus on those early years can have, both from an individual perspective for children and as they move through adolescence into adulthood, but also from a societal perspective. So we are committed to retaining our focus on those really important obligations that we have, whilst delivering on the more traditional improvements and measurables around, such as long waiting lists and access to services, because they are real priorities for our, we know from our communications from patients and concerns from our local politicians, that is a priority for them as well. So we are balancing a number of priorities across the breadth of our services that I think and hope that the overview I gave in the presentation section draws out some of the specifics against those areas. I hope that helps, Dan. Thanks.
Great, thank you, Hannah. We're going to Sarah Simmons next, who is the Director of Workforce and Organisational Development. I believe the questions have been submitted by Deborah Loganathan. I wonder, Deborah, whether you'd be able to ask your question to Sarah.
Yeah, thank you. Can you hear me okay?
Yeah, you're sounding great.
Great. I can't remember exactly, but it was it's kind of two parts. So I used to work in emergency and I tried to change to GP training and found it incredibly difficult. There was a mountain of bureaucracy, and in the end I gave up. I wasn't able to overcome the challenge of just changing to a different specialty within medicine despite having 10 years of experience, which I found very sad. Having worked in Australia, which is much more flexible when it comes to transferable skills across specialties. So the first question is related to, is there going to be any change or flexibility in relation to recruitment of staff or sustaining staff members that you've got that want to change within specialties? That's the first part. The second is, now that I'm an ESOL teacher, I work with a lot of people from overseas that have medical backgrounds, nursing, midwives, doctors, and they also ask me for help getting into the NHS. I've looked around, and from what I can find, there is no one single national UK route for international trained professionals to enter into the NHS. There are various charities and organisations that might help here and there, but getting a clinical attachment is almost impossible for a lot of them. They're asked to pay a lot of money, or they don't know people, so they're at a complete loss, and it's a real shame. So has the board got any suggestions about how it might be made easier for international trained medical staff to get work within the NHS? Thank you.
Hi Deborah, and thank you very much for your questions. I think in terms of the first question about training and retraining, as you'll be aware, there's the traditional routes, which I assume may have been the route that you tried to take in terms of GMC and our Health Education Improvement Wales pathways, which are supported by Royal Colleges. So some specialties have programmes that will support to change from one specialty to another. And then also within the Health Board, we do support employees through a portfolio pathway, which is previously known as CSER, which you may be familiar with, and that will help them, for our internal employees, to move from one specialty to another. That's in terms of the pathways which are available, and there may be some of your experience trying some of those wasn't as easy as it may sound, as these things never are. But those are the pathways that we're aware of and that we support, and very happy to have another conversation with you in terms of your experience, so we can feed that back through to our colleagues in HIW and also our medical colleagues. In terms of the second question, I think it's fantastic that you've got that connection with doctors who may have trained internationally and be looking for work within the UK. We do support one programme which supports asylum seekers and refugee doctors, which is currently in train, and I can again share more detail with you about that programme. And we also, as a health board, run a medical observership programme, which again, I'd be happy to share the details of how people can access that. That specifically allows international medical graduates to gain an overview of medical processes and systems within the UK, and have a special attachment with us where they can gain advice in terms of progressing their careers in the UK as well.
Okay, great. That would be really great, because I've asked around and nobody came up with that as even existing. So it's the first time I've heard of this. So I'd be very interested to find out more. Thank you very much.
Thank you.
Brilliant. Thank you both. So we've got 5 questions submitted during this item so far, but just before we get to them, we're going to finish our last of the advance. The question has been submitted by Chris Kemp-Philp, who isn't with us today, but Leanne Watkins will be coming back to you, if that's okay. Please, the question is, please can you confirm if you are looking into the situation of disabled patients actually getting scans that are needed, as the hospitals do not have suitable hoists to lift them to be scanned, and if possible, what they are doing to rectify the situation so that disabled patients can be treated with dignity and in a timely manner. And that hospitals do not have scanners and hoists that are not fit for purpose, leading to some disabled patients being or not being treated the same as able-bodied patients who can be scanned when needed. Thank you, Leanne.
Thank you for that question. Just to confirm, so our radiology departments use various methods to transfer patients safely and with dignity. This includes not just hoists, but trolleys and specialist slings. So it can be quite a complicated algorithm, really, to make sure that patients are scanned safely, dependent on the type of scan that has been requested, as this will vary dependent on the scanner that's being accessed by the patient. Not all sites have hoists, but alternative arrangements are made if necessary, with appointments being scheduled for patients to ensure that there are hoists and equipment available based on the scan that's been requested. Sometimes a patient may walk in and we're not aware of them turning up. So there can sometimes be a delay with the hoist being provided on the day, but staff communicate clearly with patients if this is the case. Staff are aware of the need to ensure that any specific access requirements are recorded on the patient record to ensure that the scan can proceed without delay on the day that it's planned as well. We are aware through some feedback that we've had that sometimes we haven't had specialist slings that go on the hoists, but we have remedied that and purchased them. So I think that should answer the question.
Thank you very much, Leanne. So we're going to come on to the questions that have been submitted live this evening. We're going to go to Angela Sandals first. I wonder, Angela, do you want to read your question out yourself?
Yes, please. First of all, can I just say thank you? This has been really informative. So I'm an elected member in Monmouthshire, and I'm interested in how you've managed to reduce your agency spend by £18 million, which is, 33% of your original spend. So that's no mean feat. I see you filled 500 vacancies. Did those new employees help on that £18 million saving? Can you elaborate and tell me a little bit about that, please?
So I think Sarah Simmons, first of all, to respond to the question, and we might bring Rob Holcomb in from a finance perspective.
Thank you, Dan, and thank you, Angela, for your question. The additional staff most certainly helped with our ability to reduce our agency spend. I think Rob shared earlier that our substantive costs increased and our variable pay in terms of including agency spend decreased. We had a programme of work which included a huge effort in terms of recruitment, specifically in areas where we were using high volumes of agency. So we've been able over the past financial year to reduce our registered nursing vacancies, to reduce our medical vacancies, and more significantly for us, to reduce our healthcare support worker vacancies, where we were previously using a high volume of of agency staff, and that's definitely through credit through our colleagues across the health board in all of those professions, which have really thought very creatively about how we signpost our adverts, how we design our jobs, and how we make it as easy as possible to allow people to experience what work in the health board is like, and to bring people in. There were a series of open days held by our nursing colleagues, which were very effective, for example. We also had a huge programme of work to retain our current staff. Post-COVID, our turnover increased to 11%, and we've been able to reduce that by almost 2%. And that has really supported our ability to reduce our reliance on agency. And importantly, we made some reviews and checks and balances against our governance and process and procedures in terms of how we undertook a process of booking agency staff, for example, and really targeting how we do things differently to reduce higher cost agency, because not all agencies charge us the same. So we very much targeted some of those what we call off-contract agencies, which usually have more premium spend against them. So I think it's been a huge effort for the previous financial year across the health board by all of our colleagues in services and the professions, really supporting us build sustainable teams for our well-being of our staff and patients. We've got lots more work to do. And there will be more work over the forthcoming year and the years ahead, I'm sure, because our strategy overall is to support a substantive workforce.
Anything to add, Rob?
I think Sarah answered that comprehensively. Thanks.
Great. Is that okay, Angela?
Yeah, that's great. Thank you very much.
Thank you very much. Reggie Dovner, we're coming to you next. I've read you a question and we think that'll be best answered by Leanne Watkins, our Chief Operating Officer. Reggie, would you like to ask your question yourself?
Yeah, that's fine. So I'm a candidate for the Welsh Youth Parliament in Caerphilly, and one of my 3 priorities I picked when I was filling out the form was mental health for young people, which is a huge issue across the whole Caerphilly Serith constituency. So I'm just wondering, how will you improve mental health service referral times for young people?
Thanks, Reggie. It's an excellent question, one that's close to my heart, having a 16-year-old son in Torfaen as well, actually. And it's a key priority for the organisation too, and a great thing to be championing, I believe. So thank you for your excellent question. So I think the first thing to say is that the organisation takes this very seriously. Few things just to flag really, but we had, because of our concerns around waiting times and ensuring that children and young people have access to mental health services in a timely manner, we have undertaken an improvement programme of work. The service already had running, but it now has very rigorous executive oversight to make sure it's delivering as we would expect for our population. So we had a series of papers into our executive committee, and then there's a weekly performance meeting that I chair sort of through my office, I think, just to keep track of the plans and ensure that we're delivering for the young people of Gwent. There's a range of different things that we have done, because I think particularly post-COVID, we've seen quite a significant backlog of patients build up, and we know that waiting times have been longer than we would anticipate, and that's not great. So we've been working with some external companies around providing some additional resource and workforce they're very that's been very effective. We have recruited additional staff as well, and again, important that we have properly sort of suitably qualified staff, I think, to support our children and young people. But I think what I would want to draw attention to is that we consistently work with children and young people and families in terms of the redesign and transformation of our services, checking in with you guys that the care we are providing and the services and access to services are adequate. what the team have worked really hard. So we look externally around provision of our care, and when you benchmark us against the rest of the UK, we perform very well in terms of the range of services we have available for our children and young people. So there's a detailed CAMS benchmarking report, and we provide 25 out of 27 of the services that they recommend for service provision. That by far is the most expansive in Wales. We know we can do better, and we're committed to that as well. But one of the things that, again, I'll just finish on, because I think this is really important. We talk a lot about integration, but we're trying to bring our teams together so that it doesn't matter where you present, that you have the most seamless care. So we have a range of therapists and nursing teams and medical teams working together to wrap around the patient at the earliest possible intervention. We don't want to intervene at crisis points. So we've put some in-reach workers into schools as an example of that, so that we prevent, I guess, deterioration. We get in to patient need much sooner. So by trying to be flexible and accessible in terms of the range of interventions that we provide for patients, we believe that mental health and well-being of our children and young people won't deteriorate, and will be better able to support.
Thank you, Reggie. Great. Thank you very much. So we come on to the next question. That question has been asked by Councillor Ian Chandler. Councillor Chandler, would you like to ask your question? And Jennifer Winslade, our Director of Nursing, is going to be responding.
Yeah, thank you for that. Yeah, it's, reading through the report, it struck me because breastfeeding rates in Wales already are one of the lowest in the world, which is quite an issue of shame, I think, for our nation. But I was looking through the report and seeing that actually the Gwent figures are even worse than the Welsh average. So given the importance of breastfeeding, both in terms of the equalities agenda and reducing social determinants of health, but also looking at life chances and that first 1,000 days that the WHO and UNICEF are very keen on. What are we doing differently, or what are we planning to do differently to try and turn that situation round? And particularly in terms of not just intention to breastfeed or starting breastfeeding at 0 weeks, but actually continuing it through to the 26-week target.
Thank you, Ian. That is a fantastic question. I'm a health visitor by background, so I am very passionate about this subject, and I am very pleased to be the exec lead for breastfeeding in the organisation, but also jointly with Tracy, our Director of Public Health, we lead for children and young people's sort of services overall. One of the most important things, I think, is that we get the best start in life as soon as possible. So we've been working with our maternity services to make sure that there is a programme of work which is about encouraging breastfeeding from the earliest point, but not just encouraging breastfeeding, but actually actively supporting that. We have a new data system in maternity services called BadgerNet that enables us to track breastfeeding rates at delivery and in the first 14 to 28 days. But also we've had a number of initiatives, such as we have a skin to skin initiative, so encouraging that skin to skin contact we know is so important for breastfeeding early on. Supporting our new mums with, we have an infant feeding midwife, we have a public health midwife. We're looking to be able to provide frenectomies locally for tongue tie, so again encouraging breastfeeding as early as possible, but also making sure that we're providing that support in the early days. We're also encouraging and making sure that we're offering women that support to breastfeed within the first hour of birth, and we are working collaboratively across our midwifery and health visiting services to provide peer support groups in the community, but also specialist support from a specialist midwife, specialist health visitors in the community if people are struggling. We obviously continue to monitor breastfeeding rates through our Healthy Child Wells programme. I've personally chaired a health visitor improvement board. We did have some difficulties and gaps in our health visiting service, but we've really made huge inroads in terms of the provision of health visiting services locally, and we're much more able now to ensure that the contact with families at those critical periods at 6 weeks and 26 weeks are undertaken in a timely fashion, so we can encourage women to continue to breastfeed for as long as possible. So we have lots of opportunities to be able to provide that ongoing support. We are looking at baby friendly accreditation. Whilst it's an accreditation, at its heart it's about improving that infant feeding opportunities, and we've also looked at making sure that those local community support groups are in place, and that we have local clinics where women and families can access help and support. Tracy and I are also leading for the Health Board the Best Start in Life work. So we're focusing on the first 1,000 days and the way in which we can support families to enable them to provide breastfeeding support throughout that period of time, but also have the opportunity to make sure they get the broader support for their families that they need at that time. So parenting advice, sleep advice, and other programs of work which really enable families to really focus on the health and well-being of their baby and young child. So we have lots of work in train. I'm very happy to speak offline, but I'm very energized by it because of my professional background.
Thanks, Jennifer. I mean, that sounds a lot there. I hope it reaps dividends, though, because there's a big mountain to climb.
Thank you.
Ian, I wonder if you want to stay with us. You've asked a second question. We'll take Jenny away, and we'll add Rob Holcomb, who's the Director of Finance and Procurement, for that second part. Do you want to carry on with that one?
Yeah, sure. Happy to. I mean, obviously, yeah, the going through the accounts, there's an accumulated deficit in terms of the spending of the Health Board compared with its allocations. If, you know, and as someone that has to manage as a cabinet member for social care, having to manage, don't have that luxury of overspending without any repercussions. So I just wonder, in terms of the intention to try and bring spending back under in terms of within the allocation, but what are the efforts that are being made to do that? But most importantly, from a citizen's point of view, is what's going to be the likely impact of actually making those savings in order to start coming in on budget.
Thanks, Ian. That's a question that has given us a lot of focus, especially me exercising that over the last couple of years. So good question. So I think before we get to the decision to potentially impact services, we've got a lot of other steps to go through. So we did, for the last board meeting, provide a route map to 3-year financial recovery. So I'd reference that for some reading for yourself if you'd like to go a bit further. I think as an organisation, we are trying at all attempts to not impact services adversely. I would reflect that safety first is a mantra that we are following and a priority that we are following at every decision we make. So that is never in any doubt. There's no question about making decisions that has an impact on patient safety. So just to reiterate that in terms of how we do our decision making. We've got, as a historical organisation, a massive organisation, we do have opportunities to improve our financial performance that don't have to impact services. And over the last 2 years, we've given that the most focus that we can. So there's things like improving our decision making when we're purchasing, recruiting people, things like that. And we've got a program around that, linked around what we call our value and sustainability board. And again, some of those reports are public, so I direct you there. Probably the most helpful is the most recent one that we've done, which I believe is on the website or due to be at some point soon. So there's various steps we can take. So we've got thematic areas we're looking at where we've had some success. Variable pay and agency we've touched on as part of the presentation. That's been a brilliant success for us. It improves the quality of services we can provide for people when we've got employed staff. Quality of staff and motivation is better, and obviously the economy of local staff recruitment improves as well. So that's all positive. We've got other areas we can go, things like drug switching, where we've got we can prescribe drug X instead of drug Y, exactly the same impact of market forces and other reasons that it's cheaper to buy. And we put a lot of effort and a lot of resources to make sure that our prescribing follows best value. But you've also got the prudent healthcare and value-based healthcare approaches, where looking to do the best we can for patient outcomes while making sure that the resources, either the staff or the drugs like I've just described, are effective but also cost effective. So there's various approaches. I'd go on to say things like we are looking at effective care and removing variation where it's not proven in terms of not delivering effective care. And moving on then, and again, this is all before we actually start talking about taking services down. We may change services, but there's something around, as a big historical organisation with a footprint of services that have been there for years, part of our work now is to consider economies of scale, synergies, dehospitalising care. We're also considering where we provide care and making sure we're getting best cost effectiveness and best outcomes for patients through our service models. So there will be change, and there'll be intentional change for improvement, and the scale of that change may require quality impact assessments that are undertaken by our clinical advisory forum, and potentially, depending on the scale and the circumstances, may need public consultation as well. So that brings me to actually answer your core question, is what are the impact on services? So anything that is a residual financial gap for us is a decision the board needs to consider around, do we continue to deliver services and generate a deficit, or do we take financial balance as a priority? So it is a question of priorities. And I hope you can see from what we've reported today and other reports is that service delivery is actually taking precedence at this point in time, and that's reflective of the demands on the service from patients, both in the urgent care regime, but also in terms of the some of our waiting lists. We have had to take some action, but to actually get to the nub of your question, we may end up having to prioritise what we provide as services. But there's various actions around that, like I said. So we could rationalise where we deliver services, but still provide that service. We could look at slowing down service delivery, but still provide that service. And where we don't want to go, and we haven't had to yet, is actually stop services. We haven't done that yet. And we hope that we won't have to be in that position. Now, we've developed a 3-year route plan and route map to financial recovery, but that's based also on service sustainability redesign as well. So the aim is not to reduce our effective care portfolio. We may remove ineffective care, and where there's significant change, we are hoping to actually generate an economic benefit out of that, either through improved efficiency, effectiveness, where we won't necessarily need to put more money into a service, or potentially we could remove cash and maintain a level of service. So it's a, I'm sure I don't need to explain, it's a massively complex environment we're operating in. But hopefully that gives you a sense. A very long answer, I will apologise, a very long answer, but hopefully I got to the nub of your question in the end.
Yeah, no, thanks for that. I wasn't expecting a simple answer to what is a very complex issue, but yeah, thanks for giving us that overview, and I will follow up by looking at your recovery plan papers for the last board meeting, I think, and then follow on from there. But yeah, I don't envy you that task, but
Thanks,
I don't
guys.
envy my own task in terms of balancing the social care budget either. So it's just a challenge we all got to face.
Thank you.
Thanks, Ian. Thanks both. We've got just less than about 4 minutes left of this item. We've got 2 further questions that have been submitted online by Julie Thomas, but Julie Thomas has left the meeting now. We are going to ask and answer the questions, but we will follow up in more detail to Julie in writing. So just a summary response. I think we'll come to Hannah first for the first one. Hannah, how are we working with Powys Teaching Health Board in Powys? You mentioned South East Wales, but not Powys, as a peculiar range of issues in accessing hospital care.
Yeah, thanks. So I'll keep it brief. Powys are really important partners for us, as you'd imagine, especially South Powys. The flow of South Powys patients into our services is an important flow. So a number of ways we engage through what would be the sort of traditional commissioning mechanisms, which is really important, sort of bilateral, two to two relationship. We also engage very specifically on service proposed or emerging service change opportunities that work either way, really. It's not just us engaging with Powys, it's them engaging with us. So we often jointly meet with CLICE about some of those emerging opportunities or engagements we need to have and conduct them jointly as appropriate. And of course, a key point now as we move into our Neville Hall service planning, we'll be bringing Powys into that space in terms of the opportunities and potential developments on the Neville Hall site. So we are committed to working with them and we'll keep them close on that. And we have had a recent session at an all Wales level, mapping out all the potential opportunities, and it makes it very stark, really, the Powys complexity in terms of the number of ways they look. So just to give assurance that they are very much part of our sort of stakeholder engagement mapping and development work. I hope that's okay, Dan.
Yeah, great. Thank you very much, Hannah. And the last one is more of a statement than a question itself, but I wonder, Sarah, if you've got any further comments. Julie says that getting accreditation for international health qualifications accepted in the UK has traditionally been almost impossible to get through the gatekeepers. Do you have anything else to add to that?
As well as local recruitment, we undertake a programme of international recruitment, and we work with internationally educated doctors and nurses and other professions with their professional body to make sure that we can help them through these processes once they're engaged with us. I think if there were people who are already resident in the UK and looking for advice on how to get accreditation, then I would advise them to seek support from their professional body in the UK, who should be able to support them in terms of getting that accreditation that they need or signposting them to the right place.
Lovely, thank you very much. Chair, we've got through all of the questions asked of us today, so that draws the conclusion to item 5.
Thank you very much, Dan, and thank you very much, all of you, for your very, very helpful questions and your continued support and interest. We really do value views on our services because we can't really improve properly without them, and we do welcome them. So even if you're being critical, we really need your views because they help us to improve. We're not complacent about our performance, and we'll continue to strive to improve and develop our services for the community so that our services really reflect the needs of those communities and we can provide them in a cost-effective way so it's sustainable. I'd like to thank all our partners for the support they've given us over the past year. It's not been an easy year for any of us, and your support has been really appreciated. And of course, our staff have been absolutely excellent. and we admire them very much for all their hard work and their dedication. But none of us would be here without the community, and it's you that will drive us, and that's quite right too. So we really do appreciate your views and interest in our services and how we can provide them best for you. Your response during the consultation on the potential strategy for the next 10 years has been really, really helpful. And I think that when you see it, you will almost hear your voices as we describe the future, as you have told it to us. That's been really, really helpful. And we shall be doing more work on that strategy with your help and support over the next few months. So thank you very much for coming tonight and for your very helpful questions, and for your support over this next very difficult year. And thank you to the executives for all their hard work, and to the board members who interrogate them very, very well indeed, to ensure that we do provide high quality care for the population which meets their needs. So thank you to you all, and good night.